Hi friends, good evening. Now let us talk about the cardiac abnormality that probably we are able to pick it up at the first semester. Okay, so there are few things. All these things when they come together, and therefore we are able to make the diagnosis. First is definitely the technique and the experience of the operator. But second thing is the machine on which we are working. So if you do have a good machine, then probably the resolution increases and we are able to pick it up. Third and the foremost, and which is very, very important, is some amount of the luck. Though that gives you the fetal position, which is very appropriate and very, very sort of an critical at that juncture when we are doing the scanning. And that gives you the idea or that hint or that hunch that probably we are dealing with something, and therefore that leads to the diagnosis as far as the cardiac evaluation of the baby is concerned, so which is very, very important. So in this case, what we have done is this, that probably we were just trying to look around for the nasal bone and we were not very happy with the nasal bone thing and all those stuff. But in the meantime we have just left the nasal bone, and then we thought that probably let us focus on something more, and then we went on to see the heart, and therefore we picked up the AVSD, which is at 14 weeks. And then in the retrospect, and then later on we identified that the nasal bone was also not there, and therefore we offered them the invasive testing and all the stuff. Right. So probably I'll show you these slides. So if you look closely, right, if you look closely, so it is very easy if you do have that idea, but it would be difficult if you don't see these fetuses at that frequently. But we can identify that the crux is not being formed, and therefore what we are identifying, this could be an AVSD. Okay, so this is a complete bifurcation, and then the crux is not being formed. Right, so this could be an AVSD as early as something around 14 weeks of the gestation, and then we try to look around for the nasal bone. So what we saw is this, that the equal sign, we could not get the equal sign, and the bone that we are getting is the nasal skin and the malar bone, right? Aneuploidies is specifically trisomy 21, which are very common. Out of 700 live-born babies, one baby can have a trisomy 21 or a Down syndrome baby. So they are as common as that. But if we talk about antenatal period, where the frequency is something around 1 by 300. So that is very huge. So trisomy 21 is definitely into our first and the foremost sort of an first diagnosis, and it comes the first at the as the differential diagnosis whenever we are suspecting anything. And once we saw that we are dealing with a cardiac abnormality in which we do have had the reversal of the ductus venosus in the cardiac, we also saw that probably this could be a partial AVSD or an AVSD in total. And then complementary to that was the hypoplastic and the absent nasal bone. So all these things they come together, but the only thing that probably we want to highlight at the moment is this, that probably the cardiac assessment can be done very nicely. It's something around 14 weeks by doing a transabdominal examination, and that gives us the lot of the confidence of picking up those cardiac abnormalities. And since all these things they come together, and therefore what we can see is this, that we can have a trisomy 21, and therefore we directly offer them invasive. And whenever we are identifying some cardiac abnormality to the baby, or whenever we are suspecting whether it is a nasal bore or a cardiac or increased nuchal translucency, it is all better to do the invasive, which is called as a coronary villus sampling. This can be very well done from 12 weeks onwards. Less than 12 weeks, we can have an oromandibular dysplasia, we can have some vascular insult, and therefore a clubfoot and oromandibular dysplasia. But from 12 weeks onwards, we can definitely do a CVS. Now the question is this, that there could be a fight between the CVS and NIPT. NIPT works wonderfully well when the ultrasound is normal. When my baby on ultrasound is absolutely normal, and I just want to rule out the Down syndrome because of the advanced maternal age, or because the double marker tests are not to be positive. So 5% of the double markers, they can be false positive. But whenever I'm seeing, whenever there is some abnormality that we have picked up on the ultrasound, it is all mandatory, all warranted. That probably we do the invasive and we do the confirmatory testing, right? And waiting for amniocentesis after doing the NIPT, waiting for amniocentesis. So meaning thereby that unnecessarily but the whenever we are thinking of taking an irreversible call of the pregnancy, so in first trimester this could be medical management, so that would turn out to be a surgical management. At 16, 17 weeks, getting the irreversible call with the pregnancy would be surgical sort of an intervention would be required so as to do an irreversible call, which is called as a termination of pregnancy. In first trimester, that would be medical. So medically we can manage, and so CVS can be done. CVS can be very well done, and then we can do wonderfully well. We can do all the tests. Whether it is aneuploidy or whether it is for QFPCR or FH or a CMA or WES or genetic whatever, so all the tests can be done, right? So there is no big fun waiting for the amniocentesis to be done at 16 weeks, and that is how it is. Whenever we are identifying some abnormalities on the ultrasound, it is all better to do the invasive, the needle test, right? So as to confirm the diagnosis, and to do it ASAP, and so as to clear those clouds out of the mind of the clinician as well as of the patient, and to take a call, whatever call it is there, to continue or to take an irreversible call with the pregnancy, right? Thank you very much for your patient listening.